like to offer the listener, I'm sure you've listened to some of our episodes, and we're after a desert island drug from you that evokes a powerful career memory.
I've kind of got two, if that's okay. Is that all right?
Well, let's see how you get on with the first one.
As you know, Steve, I'm married to a pharmacist because I think he was your boss at one point in Manchester.
Oh, hierarchy.
The other way round, actually.
Yes, he was an associate of Steve's.
Yes, that's right.
Yes. But I met him when I was a pre-reg pharmacist working at Bolton Royal. And he was already working as a pharmacist then, back, I think it was a C grade, so back on the old Whitley scale. And we were in the dispensary together, and, you know, everyone's working away and busy, and, you know, it's...
Before robots,
yes. And it's, you know, and I'm probably thinking, what am I doing? I haven't got a clue. And I knew he was checking prescriptions at the time, and he was checking, I think, you know, like the baby prescriptions, you know, like maybe for like vitamin K, and, you know, like they don't have, you know, at that point, they maybe don't have the child's name on it because, you know, the parents haven't decided what they want to call their baby. So it might be Baby Smith. It was just really quiet, you know, and he just turns around and goes, wouldn't it be great to call like a baby girl Ishbagula? And I sort of thought, I was like, looked at him, and then because I'm quite easily amused, I actually thought this was really hilarious, and I'd never really spoken to him before. And then that's kind of where sort of the bond happened, and, you know, the rest is history, so to speak.
But hang on a minute, we talked about this in the last episode, didn't we, Gimmo? It's Spagula, surely.
Oh, you see, what it says is Spagula, and funny enough, actually, then many years later, when we, you know, we did have our baby girl, he did actually suggest that as a name.
Nice, yeah.
Like, no.
Yeah, we'll let you have his Spagula. What was your second one then?
Well, it's just, I suppose if it's a career, it's more my career drug, I guess. Being a diabetes pharmacist and working in, you know, in the past when I was at Salford Royal, and obviously working in medicine safety, you probably can guess what it is.
Warfarin.
Diabetes pharmacist.
Diabetes, Steve. Pay attention.
I really have had too much wine before I did tonight's episode.
Insulin, is it?
Oh, yes. So I think insulin has basically haunted me for the last 17 years easily, plus. So yeah, I've just been involved in numerous pieces of work, even when I was working in Salford, and, you know, I kind of realised that the practice of prescribing insulin varied, you know, from ward to ward, and there's no standardisation to it. So I was involved in, you know, design of, you know, IV sliding scale charts, subcut insulin chart. And then when I took up the job in Northern Ireland, the team was actually already in place. We've had the equivalent of the MSO since, you know, 2002. And the team had already done like a fantastic piece of work on insulin, or, you know, a failure mode effects analysis. So, you know, really breaking ground really and using that sort of technique.
I like that you describe you've been haunted by insulin, Angela. I love that.
Absolutely. Okay, well, we'll definitely take insulin, and okay, I'm feeling in the right mood tonight. We'll take Isfagula Husk as well. Okay, what about a career anthem then for the Oral Apothecary Spotify playlist? What are you going to give us?
Okay, and that was a really, really difficult one for me because I've always been a wee bit of a muso, and really up until probably I've had my kids actually, and I was really into like the whole, so for me it was a really hard choice because I actually, what brought me to Manchester was the whole Manchester, you know, indie scene. And that's really why I wanted to study pharmacy there and, you know, see all the bands and dance in the Hacienda. But I think my true obsession has always been the Doors. I think I was lucky in that. So I'm the youngest of 7. So I've got, you know, obviously lots of brothers and sisters who are also into music. And I got to inherit their Doors collection. And for me, that my song choice is Break On Through. And whilst it wouldn't be one of my favourite Doors songs, I think it kind of really embodies my working ethos. And the song is about breaking through the doors of perception, which Jim Morrison actually stole from William Blake, who was the English Romantic poet. And it's really about looking at things from the other side, you know, not looking things at such a black and white perspective, and questioning maybe why things are done certain ways, and, you know, the design of things, why is it like that? And so I think it's always about, you know, asking, is there a better, easier, maybe more efficient, safer approach? And I think that really, I suppose, is why I've ended up being a medication safety pharmacist. So
Sounds perfect. From everything you've just said about the medication safety work that you've done, you've absolutely nailed it in relation to looking at it differently. Okay, we'll definitely take the doors and break on through. What about a book then for our listeners?
Okay, and that was actually quite hard. And I think actually, just as well, I didn't say Adam Kay book, This Is Going to Hurt, because I was thinking about that. My lockdown hobby was to take on a postgraduate qualification in human factors.
Like you do.
And I suppose I've been immersed in it. But one of the books that we got, and it's not a textbook, it's really a book of books, really. It's called Human Factors and Ergonomics in Practice, Improving System Performance and Human Wellbeing in the Real World. And it's edited by Stephen Shorrock and Claire Williams, who are both chartered ergonomists. And I think really for me, it's what I find, I think for human factors is to get that understanding that it is actually a scientific discipline. It's which isn't something that really you can just do in a short sort of training sort of event. And it's really about understanding the interactions among people and the other elements of systems and optimizing these to achieve performance and well-being. You have to think about obviously then that sort of the physical, cognitive, social, technical sort of system design aspects. I think what this book does, it's a good book to dip in and out to see how human factors is actually applied in many other complex industries. So the rail, oil and gas, even agriculture's in there. But even actually talks about human factors with regulatory bodies and research, and also practical things about communicating to the board and things like that. So, and there is a section obviously on healthcare, and there's key contributors to it. The big names like Sidney Decker, Eric Holnagal, Ken Catchpole, and I think it's a nice book if you just want to dip in and out, learn a wee bit more about human factors, know what it's about. And I think for maybe people who are a bit like me, who are a bit time poor, it's kind of one of those wee good sort of reference books.
Well, we'll definitely put it in the show notes so that people can see what it is. But as we've been talking a lot about human factors, that sounds like a perfect choice.
But I just would like to say that there is actually a book I have started, which I think you should have on your radar, and it's called Still Not Safe, and it's by Bob Wears, and who's, I think, kind of expert in patient safety in the States. And it's actually about the whole rise of the patient safety movement. I think it'll make it quite an interesting and challenging view on what we believe as being the movement. So I definitely think one to put in the library, yeah.
Okay, next up, it's our micro discussion. STC, what have you got for us?
So we thought, particularly as we had Angela on tonight, that we would have a look at something that was published online in the Research in Social and Administrative Pharmacy in December last year, which was about evaluating the impact of a pharmacist-led prescribing feedback intervention on prescribing errors in hospital sector. As Angela has said, that's certainly a space that I've been involved in as a researcher, and I know that Angela is certainly interested in this, and I'm sure that both you, Gimmo, and Jamie have seen stuff, because without going into too much detail, without having the time for it, it's a really good study, to get in that paper with a very, very high impact factor. You have to have a reasonable methodology. And of course, there are methodological flaws in all studies, but essentially they did show a statistically significant reduction in prescribing errors from doing repeated audits.
I'd ask you to leave the pub if you came out with that, okay? I'd ask you to stand up,
Why?
Put your drink down and leave.
Why? What's up?
We don't want critical appraisal.
Shall I start from the top?
No, not at all. Carry on.
And I know Michael. I've been working with him.
Yeah, in fact, I forgot to mention his name.
Michael Lloyd.
I know it's Michael Lloyd. I'm going to start again.
No, you can't.
Okay. Yeah, I think we can.
This is staying in, Steve.
Yeah.
I also know Michael Lloyd. No. So the authors, Michael Lloyd and co-authors, have done a great job here. And what they've shown is there's statistically significant reduction in prescribing errors in the intervention group versus the control group by giving feedback, but feedback that's timely to the prescribers about any prescribing errors that they might have made.
I'm going to come in with my quote, and this is from a GP, eminent GP, 29-year career in South Wales, and he said, I've probably poisoned more patients than I've cured. And when I share this sentence with workshops and audiences, and I say, what's the word that jumps out at you in that sentence? I've probably poisoned more patients than I've cured. And people are pretty shocked and they jump straight to the word poisoned because that's not really a great word to see. But actually, once we've just chatted about it for a while, people get it. Actually, it's the word probably. I've probably poisoned more patients than I've cured, and the fact is that we don't know, do we? And so there is no feedback in the system on a lot of our systems. So this paper, it talks about the human factors are in there again, looking at the contributory factors. I'm interested in the skills the pharmacists need to be able to have these conversations with prescribers and junior doctors in a, non-threatening, facilitative, educational way. But I've used that sentence a lot in workshops, and it's a real conversation starter.
Yeah, and I think that's one of the things that I was interested in reading it, is that idea of feedback, because Angela will know this if she's doing a course on human factors, but one of the common things that are built into safety critical industries is that immediate feedback loop when things start going wrong, but also then when things do go wrong, what do we learn from that error? So there's two sorts of feedback there. Most of the time when we report things into the old NPSA database or Datex or Yellow Card or whatever, there's very little feedback to the person who made that error. So I think this is great to see. I mean, it's not new, is it? It's not a new idea, and it's not an original concept for study, but it does really helpfully add to the evidence base. I wonder in things like this as well, what does it do about the relationship with the prescribers? Because I can remember when, I was a community pharmacist, and in some of the shops, some of the pharmacies I worked in, your relationship with a GP purely consisted of you ringing them up to tell them they've made a mistake or they'd prescribed something wrong. So it didn't exactly make for a brilliant relationship, because they came to dread the call from the pharmacist, because it was like the call of doom. So I wondered if they looked at that in this study.
I was just going to say that, you see, feedback in itself has quite negative connotations, implies that it's one way. And I think where this now is evolving, because I know Michael actually, who's the author of this paper, and he's been working with some people in Northern Ireland, and I've been sort of part of this as an external partner, and Karen Maddock in Exeter University, and we're looking at more about, it's optimizing those conversations, well, safer prescribing or optimal prescribing, and you hit the right note there, Paul. It's about behavioural changes and making commitments for changes, and the work that I sort of alluded to earlier, that with Tim Dornan around the kind of the insulin aspect of what we're going to do with the kind of giving junior doctors feedback, it evolved into that. Tim's an international expert on medical education. It was the whole thing around the COM-B theory, which is the capability, opportunity, motivation, behaviour. So for behaviour to occur, an individual must have capability, opportunity and a motivation. So you increase availability of support to the prescriber, or, the prescriber has, help-seeking behaviours, and that obviously, can improve the outcome. So the work even that we did in Belfast, well, in Northern Ireland actually, was to use the case-based discussions that doctors have to have for their e-portfolio, and framed a kind of a tool to help the junior doctors cope with situational and self-awareness. So that was named Smack Squared, which I did say to Tim. It does like maybe you're giving them a smack on the back of the hand, but anyway. But what it means is SMAC stands for situation, myself, action, check, and check again. And I think, Steve, you actually mentioned this at a previous podcast about checking your prescribing again. What was the outcome of that? What your decision, what did that lead to?
Going back to the Adam Kay book, right? Really fascinating. Very early on, he talks about the difficulty about being a doctor in night shifts, loads of stuff going on, but you never get to find out what happens. And he said that, he couldn't learn and improve because he couldn't reflect on the decisions that he'd made because he didn't know what the outcome was. So in the conference today that I was speaking about my prescribing journey over 20 years, and the first 5 years were illegal prescribing in inverted commas, where I was adjusting people's warfarin dose. But do you know what? That taught me the value of seeing the decision that I made, sometimes with the patient, as to what to do with the dose. I would then get to see the result of it. And to this very day, I think I said this before, I still go looking for difficult patients to see what happened to the decision that we made between ourselves. So this feedback thing is definitely part of that. And the other thing I would just say is lots of stuff at the conference today about artificial intelligence. And if we're going to do some heavy lifting here, because this is very intense, I've been involved in some of these studies, it's very intensive to train the pharmacists and for them to give that feedback so that it's timely and it happens within 24 hours. Maybe bots and artificial intelligence will allow some kind of that quantitative data to go back, and then the qualitative stuff can come around it.
So from the sporting world, the high performance systems, our superstars go looking for the feedback. All these high performance systems in elite sport, that they they rely on feedback, but actually the people that we know, they're the ones that are doing extra, but they're the ones that are seeking feedback about their performance. They're not waiting